Hello. In this new video, I will be talking about what do we mean by quality of the evidence and how to rate it according to the grade system. If you remember from the first video, rating the quality of the evidence is the first step of the grade system. We always start with a structured question, and that typically is done in a PICO format, population intervention comparison and outcome. So that's the first step. Structured clinical question. Very important in grade, the selection and rating of the importance of the outcomes. We are only interested in those critical for the decision. And that is something that has to be done upfront. This is typically done not only in grade, but also in systematic review methodology nowadays. And why is it important? Well, first, because those outcomes that are critical are the most important for the decision, and those that should have the most weight in our final decision. And second, because we're going to consider, and this is typically something that grade started, we're going to rate the confidence or the quality of the evidence, not overall across the range of studies independently of outcomes, but we are interested in the quality of the evidence per outcome. So for each outcome, we're going to review the evidence. There might be 4 studies informing outcome 1. There might be just one study informing outcome 2, and so on. They will have different strengths and limitations, and therefore our quality or confidence in the results will be different. Given that we have several outcomes, different confidence or qualities and results for all of them, it's very useful to put them all together in a table, and I will be presenting in another video about a structured presentation of those 2 pieces of information. Okay, once we have all this laid out, and per outcome we'll have to decide whether we have high, low, or moderate, low, or very low quality per outcome. So grade rates the quality from high to very low. And for doing that, we'll have to decide first, what do we have in front of us? If there are randomized trials, grade suggests to start with high quality. If there are observational studies, the suggestion is to start at low quality of evidence. In the case of randomized controlled clinical trials, per outcome first, we have to decide whether our confidence or quality or the qualities it's really high, or if there are any concerns about the different factors: risk of bias, consistency, indirectness, imprecision, and publication bias, and I will be talking about those in a minute. So those are the factors that will decide upon the quality of the evidence. And this is the definition of quality of evidence by grade. So the extent of our confidence in an estimate of effect. And our confidence will depend on the design of the study and on the factors I just mentioned. So confidence in an estimate. This cartoon is very illustrative of what I mean. It's 2 weathermen talking to each other. And one of them says to the other one, I figure there is a 40% chance of showers and 10% chance we know what we're talking about. So these 2 guys are really talking that they have a result, so 40% chance of rains, but the quality of the evidence or the confidence they have on that, it's the uncertainty dimension, the 10% chance we know what we're talking about. So 2 dimensions. The definition I just mentioned, it is a definition of quality of the evidence in the face of a systematic review. In the face of guidelines, it is slightly different. Instead of the confidence in the estimate of effect, here is the extent to which our confidence in an estimate of the effect is adequate to support a particular recommendation. That is, in guidelines, it's not the confidence just about the result, but whether that result is enough to support the recommendation. Think about it, because I will give some homework in relation to this to you. What about the implications of the different categories of quality of evidence? Well, we can organize them or frame them in relation to the need of research. So if we have high quality evidence, that is, we are very confident, well, it's unlikely that further research will change that confidence. If the confidence or the quality is moderate, well, further research is likely to have an important effect, and so on, all the way to very low quality, where we are really uncertain or not sure. So any estimate of effect or accuracy is very uncertain. Any research might change the actual results. Okay, so as I just said, the confidence starts as high in RCTs or low in observational studies. And these are the 5 factors I mentioned before. So we'll be talking about the 5 factors briefly that might decrease our confidence in a study or in a set of studies which have a randomized controlled trial design. Risk of bias. The higher the risk of bias, the less confidence we will be. And here you have issues in relation to randomized trials and other types of studies. For example, typical of randomized studies are the first 3. We have to be looking at whether it was randomized, well randomized, whether it was a concealment of the allocation of the randomization, whether it was appropriately blinded, and so on. And depending on the factors, we'll have to make a judgment. Next factor, we have to look at whether the results are consistent or not. If the results are inconsistent, our confidence will go down. What do we have to look at? We'll have to look, if we have more than one study, that is important to be able to judge the consistency. We'll have to see whether the results vary. Are they very different, the estimates that we are getting? We also have to look at the confidence intervals. Are they overlapping? If they are overlapping, they will be less inconsistent. We have to also look at a statistical test of heterogeneity, chi-square or the I-square, and there are some rules for that you can consult, for example, in the Grade Handbook, if you want to know more in depth how to judge the consistency of the results. For example, look at this meta-analysis. So it's a review about patient reminders to improve immunization rates. So in this case, it's letter reminder versus control. We have a meta-analysis. And here we have the dots are representing the estimates of effects, the lines, the confidence intervals. I guess it's something that you are already familiar. And the bottom figure, it's the meta-analysis estimate. Okay, in this case, as we can see, the effects are pretty much aligned. The confidence intervals are overlapping. And if we look at the statistical test, the p-value and the I-square tell us that the results are highly consistent. So no reason to downgrade or to lower our confidence in the result in this case. Okay, have a look at this one. Clearly, now the effects are different, despite that they both favor the intervention, but the confidence intervals do not overlap. And again, now, in this case, the tests for heterogeneity are highly significant for the chi-square, in the case of the chi-square, and the value of the I-square, it's extremely high, 97%, so highly variable. Our results are highly inconsistent, and our confidence will decrease. However, before saying that we have lower confidence, we have to look for explanation of that inconsistency. Sometimes we are able to find 4 explanations and we don't have to lower our confidence in the results. We have to look for difference, for example, in patients, interventions, comparator, outcomes, or other aspects like, for example, date of publications or risk of bias. If we do find an explanation, our confidence doesn't necessarily have to go down. However, if unexplained, our confidence will be lower. Okay, the other factor, the fourth, it's the directness of the evidence. You can call it different ways: generalizability, transferability, applicability. And we have to see whether the evidence we are reviewing is directly applicable or it's reflecting our question of interest in regards, again, to the different components of our PICO question: population, intervention, comparator, or outcomes. Also, sometimes we're interested about a specific comparison, for example, A versus B, but we only have indirect data or indirect comparisons. For example, we have only A versus C and B versus C. For example, there are many studies comparing alendronate or other biphosphonates like risedronate to placebo, but there are no head-to-head studies. So we have indirect data to answer that question, and therefore our confidence in these results is lower than if we had head-to-head comparisons. Imprecision. The less precise our results are, the less confidence we will have on the effects. What do we look at? Well, we look first at the number of events. The lower the number of events, the less precise typically the results are. We have also to look at the confidence interval. The wider, well, the less precise. And by looking at the confidence interval, we can also decide whether the confidence estimate, in the case of recommendations or decisions, whether it's actually precise enough to support our recommendations. So, for example, if on one side of the confidence interval we would do a recommendation, but on the other side of the confidence interval we will take a different decision, that confidence interval is typically called imprecise. Have a look at this meta-analysis of vaccine versus standard of care. The outcome is otitis media. What do we have? Just one study with only 24 events. This is a very low number of events. We are only in safe ground when we are talking about 100 or more events. When we mean events, it's the sum of the events both in the intervention and the control group. There are fancy and statistical ways to calculate what's the necessary sample size in systematic reviews for the results to be precise. And you can have a look at that in the Great Handbook if you're interested. But 24 events are not many, and the results are therefore imprecise. Look at the confidence interval. Also, it's wide. It goes from a very large reduction, 0.22% relative risk, to a 1.03 relative risk. So from a positive effect to a harmful effect. However, look at this other meta-analysis, many more events. In this case, we have already 250 events and a much narrower confidence interval, going from a large reduction of 0.28 to still a considerable reduction of 0.48. Now, both extremes of the confidence interval are within a result that favors treatment. And probably, in the context of a recommendation, we can call this estimate or this confidence interval precise enough, as the panel will be confident to make a decision even in the worst case scenario of 0.48 relative risk reduction. Okay, publication bias. So this is the bias caused by the non-publication of negative studies. Should always be suspected, especially if there are only small positive studies and industry funded. There are different ways of evaluating the publication bias, and they all typically need 10 or more studies to be able to be reliable. For example, the funnel plot is a graphical test, but there are also statistical tests. We have to look for a symmetrical funnel where the larger studies are closer to the true or the pooled effect Apologies, going back. So they're close to the true effect. These are the larger studies clustering around the true effect. And the smaller studies, they have very different effects, both harmful or a reduction or are increase in the effect because of random due to the small sample size. And we should have studies on both sides if we have enough studies of small size. If for some reason we do not have studies on one of the sides, typically in the side that does not favor the intervention, we should be suspecting publication bias. For example, intravenous magnesium in myocardial infarction. This is a classic funnel plot representation. We only have positive studies, even if many of them are small in size. It is very strange that none of these small sample size studies gave opposite results to a positive result. So it is quite likely that those were never published. And that is, in a nutshell, the quality of the evidence rating, the first part of the grade system. I will talk about now the determinants of quality, but not for rating down the quality of the evidence, but for rating up the quality of the evidence. And that is for bodies of observational studies. One of the features, unique features of grade, is that it's able to rate as high quality situations where there are not randomized trials. We all know that there are situations, for example, in parachutes for reduction of injuries when jumping from a plane. There's never been randomized trial and nobody is going to conduct them. We are certain enough to have high confidence in the effect of parachutes. And why is that? Well, we're going to have a look at the factors that increase our confidence in the absence of randomized trials. Very briefly, there are three. And the most known are large magnitude of effect and dose response gradient. The third one is a bit more complex. It's whether all plausible residual confounding are working to reduce the demonstrated effect or increase the effect if no effect was observed. So large effect. Before everybody was doing badly and now everybody does well. And the effect is in many instances very, very immediate. For example, insulin and diabetes ketoacidosis. No randomized trials, high confidence, high quality. Adrenaline in anaphylactic shock. You don't take adrenaline, quite likely you die. You take it, quite likely you'll be okay. High confidence, so large effect. Residual confounding. I will be giving you some homework for that. This is an introductory course, and you might get into trouble with this third factor. But think about it and do your homework.